Tes.
Oke.
Cek. Good morning and welcome everyone to this guest lecture. It is such an honor for us. My name is Iwayan Mustafa.
And me, Natania Fikiriana.
To be the host of today's guest lecture.
We would like to welcome our guest lecturer today, Professor Salvatore di Somma, MD, PhD, from Sapienza University of Rome, Italy. Professor Salvatore di Somma, MD, PhD, is the President Scientific Committee of AISC, Italian Association of Patients with Heart Failure. Good morning, Professor. Welcome to Bali. It is such an honor for us to have you here with us.
On behalf of Cardiology Study Program, I would like to extend a warm welcome to all supervisor and invited guests for taking the time to attend this event. It gives us a great pleasure to be anchor for this guest lecture, and we are excited to be hosting it.
Today's lecture aims to shed light on the latest update on management of patients with acute and chronic heart failure and how it is relevant for all of us. In today's fast-paced world, it is imperative that we stay updated about the latest trends and developments in our respective fields, and this lecture provides a wonderful opportunity to do just that.
Before we start this guest lecture, I would like to invite Dr. Putra Swiantara, cardiologist consultant, as the head of Cardiology Study Program at Udayana University, as the head to have welcoming speech and to begin today's special event. Dr. Putra, the floor is yours.
Good morning, fellow colleagues and all the residents, and obviously our distinguished guests, which we have the great honor to come and visit us. And this is your first time, Professor Salvatore? All right, great. So this is our hospital, this is our home. We've met before during the scientific sessions, and we are very grateful for all of your insights and sharing with us all here. And we are hoping that this will be the beginning of a mutual and fruitful relationship going to the forward in the future. All of us here are very honored to have you here to share your wisdom and knowledge as a distinguished speaker and a very influential people in heart failure management across the world, especially in Europe. So I will not take a lot of time. The focus is on you today, this morning. So thank you again for coming in and spending your time here. And I know this is only a half of your trip going to Jogja next week. I'm pleasantly certain that you will enjoy your time there as well. We have great colleagues over there as well. Everyone is expecting for you to share your wisdom. That is all from me. Thank you very much, Dr. Nyoman, Dr. Junior as the head of the department, Dr. Susila, Dr. Hendy, and all the other staff. Good morning to us all.
Thank you, Dr. Putra, for the welcoming speech.
Okay, our lecture this morning will be guided by Dr. Nyoman Wiryawan, cardiologist consultant, as the moderator. So Dr. Nyoman, the time is yours.
Good morning, everyone. To all residents, cardiology residents who are attending this meeting today, this morning, I must apologize first because the morning report in this day should be held because this meeting, and I hope you will be replace the all the knowledge of the heart failure from acute to chronic, but maybe Prof will be pronounced and maybe get more deeper in the chronic, because in the last meeting in Saturday night, we already began the presentation in the acute setting. To Professor Salvatore, thank you very much for coming. Again, Prof, Dr. Putra is already said, this is our home. This is our conference room, Prof. Maybe compared to your Sapienza University is smaller, but maybe we have the same idea and the same big hearts to reduce cardiovascular problems and to improve the quality of life of our cardiovascular patient. So topic today is about the latest update management on acute and chronic heart failure. Is already have the guidelines, the new guidelines in 2021 and also in 2023. The SC Congress is still going on. Thank you very much for sharing, Professor. Please, to cardiology residents, all the other staffs would like to comment or maybe give some discussion, sharing the patient. This is the time, this is your gold time to share our problem, and maybe Professor Salvatore will give us some solution or enlightenment. Again, Professor Salvatore, Dr. Junior as a Chief of Department, Dr. Putra as a Cardiology Residence Director, and all the other staffs, all cardio resident, please please to watch our Professor Salvatore to present the material. Please, Prof. Salvatore, you may begin your presentation. Thank you.
Very much, everyone, for the warm welcome. I really appreciate the spirit of this city and of Indonesia generally, and it's an honor for me to be here and to continue my effort to share with you our knowledge, because again, I think there is a lot of opportunity in this country, but especially in this institution, for young people to become the future of their country in order to contribute to better improvement of patients with the cardiovascular disease outcome. There are a lot of things that we can do together, and my presentation, there will be, I promise, no more than 30 minutes, probably a little bit less, will focusing not only on presenting the actual update of the guidelines, but also, why not, to see if in the future, in next future, we can have a kind of a cooperation together in order to promote research and also publications, because I'm sure you have so many patients and you can contribute a lot in improving their outcome, trying to, let's say, work together and also pushing the innovations into the reality in your daily practice. Before starting, I would like to mention these let's say, effort. I would like to mention the possibility for this center to apply to this international network. This network that is named Great Network is a network that is devoted to promote research in cardiovascular disease, and is including already more than 9 countries in the world, already including Indonesia, starting from Yogyakarta and Jakarta cooperation. But I hope that from now, also Bali Center, this outstanding center of cardiology, will participate and contribute, because many of these people in the network that was founded more than 15 years ago are now the contributors of guidelines, European Society of Cardiology. But people are coming also from other countries, as you see, from US, from South America, Australia, Asia, and Africa. Just to go forward, I have to ask you, I can. Okay. Again, I was focusing a little bit more. You already remember that Saturday we addressed mostly these guidelines on acute heart failure. I will try to spend my time more on the chronic phase. But if there is something that you would like to take the opportunity to discuss on what we presented Saturday, because Saturday we were a little bit more distracted for the dinner, right? So now we have a little bit more time eventually to discuss also about the acute heart failure. I think that you saw already this picture, but it is important to remind that in the next, very soon, we'll have a lot of patients with the heart failure. And let me take the opportunity to, let's say, share with you the concept that managing heart failure is really a peculiar job. for cardiologists, because it's not only to be a good cardiologist, right? It's also to be a comprehensive evaluation of our patients that many times all patients with cardiac diseases should be evaluated with the whole situation, but especially in heart failure, there are a lot of concomitant diseases, such as lung disease, such as kidney disease, liver disease that should be taken into account, right? So it is really a situation that you should really demonstrate that you are a very good skilled physician. Now, I think what is important in the guidelines, I just mentioned in the acute phase that the CHAMP is the algorithm for determining reason, but don't forget that the first step is always to understand which are the reasons why patients have heart failure. So be able from the beginning to recognize the reason that is leading the patient to heart failure is still crucial. Majority of our reasons are chronic artery disease and hypertension, I'm sure, but there are a lot of other. In this part of the country, I think valve disease is very important because you still have to fight with the rheumatic disease consequence, right? So there is a lot of things that we can do together. So let's focus today in some peculiarity that you have in this country to focus in contribution to international literature. Because I think at the end of the day, Indonesia has a lot of opportunity to come up showing the really need for future contribution. So you have a kind of a specific population that is still we need to evaluate better. You know that one of the reasons why we'll have so many increase in heart failure patients, because there is a relapse not only in this country but worldwide of rheumatic disease, because vaccination for COVID promote in the recipients some kind of deviation from immunologic system from the regular memory of a streptococcus to virus, right? So there is a lot of relapse of rheumatic disease in Europe as consequence of virus, also if it is indirectly. So there is a lot of need in the future to have your contribution. How can we better manage valve disease? And also, why not? Because, you know, there are a lot of new technology that make the cardiosurgeon intervention with robotic very easy, right? Not anymore needed to open the chest. So we can really work on that opportunity. And then there are a lot of, you know, there are many patients having COVID consequence, infections, infiltration that are going to have heart failure. So at the end of the day, you should really, from the beginning, recognize the reason in all patients with heart failure to better manage the disease. I just would like again to emphasize two concepts of classification. What is really nice that after several years still, New York Heart Association is considered a standard of care. So I would like to share with you the kind of data collections that is could be probably in the daily practice to classify some data. For instance, it is very easy to recognize the classification New York Heart Association based on symptoms, but I think that is always very important to include echocardiographic assessment, both in chronic, especially in chronic situation, where you are distinguishing again, reduced ejection fraction, lower, below 40% of left ventricular ejection fraction, mild reduced ejection fraction between 41 and 49. I really would like to, you know, there's a lot of confusion in Europe about preserved ejection fraction. They say, okay, patients has symptoms and ejection fraction is normal. Is there heart failure? No, you need to have objective evidence of cardiac structural and functional abnormalities. That's something that sometimes is missed, right? So I think it's important that all this concept has been reminded. Now, let's move now on the treatment of a chronic heart failure, because we should really, let's say, fly a little bit, jumping from some concept. I already showed the importance that in patients with reduced ejection fraction, again, please don't forget that you have to use these drugs all together. ACE inhibitor or AT1 blockers, beta blockers, mineral anti-aldosterone antagonist, SGL2 inhibitor, and loop diuretic for retention. You know, at the end of the day, these are all class 1 indication. I know that in this country, you have not yet the possibility to have the reimbursement for SGL2 inhibitor, but if we can demonstrate there are some possibility to improve your patient's outcome, there will be some possibility also to contribute to pushing Dr. Naoli with you to work into the government as heart failure group in Indonesia cardiology to promote the utilization of these two drugs. Now, I think also it's important to remember, and this is also for you an important topic, that you can have the possibility to implant ICD if there is some, let's say, in patients with a reduced ejection fraction, the QRS below 130, and when appropriate, don't forget that you should use ICD. Why I would like to outline this? Because somebody can tell me that this is costly, right? But how much is the cost of a patient coming back every year into the hospital because heart failure? You know very well, better than me, that all patients with heart failure come back at least 3-4 times a year, right? So our effort should be to reduce this recurrency of hospitalization, because we know very well every time the patient is coming, his life expectancy is decreased, right? So our job is to try, first of all, to reduce mortality, but reducing rehospitalization. So if we can demonstrate in our future cooperation that our effort, putting together all the innovations that are so many for heart failure, we can reduce hospitalization, this will be a good reason to go to the governor and say, hey, we are going to reduce the cost because we reduce the hospitalization. So our effort will be to try to reduce patients coming back. And this is really very beneficial for the patients, first of all, but also for us, right? So we can have less patients coming back. And I think this is the way, because if you are going to implant more ICD, if you are going to use also these drugs, and you are going to demonstrate that the number of hospitalizations is coming from 4 to 3, and you are going to measure exactly, this is something we have to work, right? To measure the cost of each hospitalization and see that we can impact that. Now, let me just, in the chronic phase, try to really show the importance of using the drugs. Why recommendations are 1A for these 4 drugs? Because you see, optimizing, Dr. Naoli during her speech addressed a lot of these. ACE inhibitors is going to reduce the risk of hospitalization. And the same hospitalization and death for beta blocker, mineral corticosteroid antagonist, and SGL inhibitor. This means that these 4 drugs should be used together, okay? I think it's really important that you are going to use this drug in chronic heart failure together with these other 3 pillars. And also there is possibility that you are going to replace 81 blockers, so ACE inhibitor, with the sacubitril valsartan. I don't know if it is available in this country, but there will be a lot of possibility also to improve patients, although the evidence is a little bit lower than the other. So first step is these 4 drugs. So try to optimize patients' adherence to treatment, having all the drugs in their daily acquisition. So I just would like, I love beta blockers. I have to confess that the beta blockers are fantastic drugs, because are going, when I was a student and in cardiology, it was 1978. At that time, beta blockers was not a drug for heart failure. Was even contraindicated because negative inotropic effect, right? But now I think it's really important to understand that the beta blockers are the pillars, especially carvedilol, right? Because there's a beta and alpha antagonist effect. Beta blockers should be initiated in clinical stable patients at a low dose and gradually up titrated to maximum tolerated dose. In patients, that's very important message I would like to give to you, because you know that beta blockers should be used in patients with heart failure, reduced ejection fraction. But this is very important. In patients admitted with acute heart failure, beta blocker should be cautionally initiated in hospital once the patient is hemodynamically stabilized. This is very important. So you should try to take the opportunity of hospitalization when the patient is a little bit hemodynamic to start as soon as possible beta blockers. And this is also true for SGL inhibitor. But one recommendation I will take, don't stop beta blockers in acute heart failure patient. These are big mistakes that they think that since the patient is acute heart failure, you should reduce beta blocker because it's going to impact contractility. Not true, not true. Continue beta blocker, don't stop, don't reduce. The patient go to die, okay? So you have to continue. There is no reason to stop. Of course, if there is asthmatic pneumonia and you want to reduce beta block because some kind of, let's say, lung disease makes a little bit of sense. But there is no reason to reduce or stop beta blockers if the patients come with having beta blockers with acute heart failure. Is that okay? So we can discuss about that, but it's a recommendation that I will take the opportunity to outline. Because some cardiologists, they do this. Now, what is important that, you know, we just are thinking about which are the drugs, because these are the drugs for reduced ejection fraction. Which are the drugs that I can use in case of mild reduced ejection fraction? I think that beta blockers should be considered in these patients, although the evidence is not so big. I would like to take the opportunity to share with you the importance of also using drugs that you can use, like beta blockers, optimizing. So we have to go to see the future, but why don't we optimize the present, right? And beta blocker is always something that I would recommend to discuss about how to. Now it comes the next step. Guidelines that I'm presenting are a little bit old because it's 2021. Now we know very well, and I presented this during the Congress, that we have these two drugs, epagliflozin and dapagliflozin, that is shown in this fantastic paper. This was 2 years ago, this was last year, showing that in patients with preserved ejection fraction, they have advantage to reduce mortality and hospitalization. But before that, don't forget, actually, the evidence say that in case of patients with preserved ejection fraction, you still carefully understand the etiology. So coming back on which is the best to do is recognize the etiology of heart failure. Because if the etiology and cardiovascular and non-cardiovascular morbidity are recommended in patients in terms of really contribute to their improved of outcome. This makes a lot of sense. So it is not true that you have nothing to do in patients with preserved ejection fraction. In ejection fraction patients, you should treat better hypertension, you should treat coronary artery disease, all the reason of the disease, okay? And then you can probably think about, if available in Indonesia, the utilization of a preserved ejection fraction with SGLT2 inhibitor that has demonstrated to be efficacy also in patients with heart failure without diabetes. Don't forget that these patients should be treated in the past with this drug for diabetes. But now I think there is a lot of opportunity if you are going to have the, let's say, utilization in your country to impact contemporarily the kidney and the diabetes situation with this kind of drug. I would like to outline that for Indonesia and for the Asiatic patients, there is a lot of possibility to contribute to evidence, because what's the problem of the trials, right? The trials are fantastic, but are not covering all the phenotypes of your patients, right? So this means that after the trial is published and you have the, let's say, the indication, you should put this in your daily treatment, right? And this is a little bit difficult. But if we can take into account that in the emperor-preserved ejection fraction with epagliflozin, we show that there's a lot of beneficial effect in kidney function. And you have a lot of the patients with diabetes and kidney function. There is opportunity for us in this country to show in the clinical practice some evidence that should be not probably covered in the trials, because always coming from the trials to clinical application is a little bit difficult, okay? This also important to show that if you want to compare the two drugs, the epagliflozin and epagliflozin, you see that here there were no patients with reduced ejection fraction into preserved emperor. Now, in order to try to make this presentation quite stimulating for you, I would like to address a little bit comorbidities, right, on heart failure. And I think it is really important to remember that the majority of sorry, can you come back? Yeah, majority, 40% of our patients have atrial fibrillation, that around 70% has hypertension and 50% has ischemic heart disease. When we talk about which is the drug I can use in chronic situation, you have to consider the presence of this comorbidity. You should optimize the treatment of atrial fibrillation. You should optimize the treatment of hypertension and, of course, chronic ischemic disease. So I think that is really important, and especially for this country probably, to adequately normalize blood pressure in patients with heart failure. So the first objective is to look at blood pressure that should be normalized. So you have to follow also the hypertension guidelines to make sure that the patient should be optimized. And you know, I don't have to tell you which are the drugs that you can use. It is really important in other fibrillations to consider which are the drugs that I can use. Definitely beta blockers, you know, especially if the patient has not converted in sinus rhythm, but the drugs that have been preferred in order to control better the rate, right? So beta blockers should be used in patients with atrial fibrillation. But don't forget that in acute phase, you can use amiodarone, and then you can continue amiodarone in terms to try to have the preservation of a sinus rhythm. There is a kind of debate. Should I go to, let's say, convert from atrial fibrillation or sinus rhythm? And in the guidelines, they don't say that you need to insist too much, but let me tell you that the contribution of a 30% of a preload in order to maintain cardiac output is always important. So let's try to make a concordance between the atrial function, the left ventricular, to make it sure. So I'm not sure that with the technology, especially electrophysiology, you can have no advantage to maintain, especially in situation when the heart is not dilated, such left ventricular hypertrophy for cardiomyopathy, right? There is really need to make a kind of ablation of the atrium connections, and then to maintain, let's say, kind of synchronism between the atrium and left ventricle. So also atrial fibrillation should be unusual that you have to take in account patient by patient. What about in patients with atrial fibrillation anticoagulation treatment? I don't know if in this country are available the new anticoagulant drugs, such as rivaroxaban or the garoxaban, available, right? So there is no need anymore to take the patients in decumarol, right? Or any anticoagulation, but you can use these drugs that are now really easy to use, and they are going to give a lot of beneficial prevention of ischemic stroke, and also they are really now a lot of antibody in case the patients need emergency surgeons that you can use, right? So really, I recommend to use this new anticoagulation drug more than decumarol or because you don't need to check INR. I hope that you are convinced that you can facilitate patients let's say, adherence to treatment, because now we are moving slowly to the patient's adherence. That is always one of the most important reasons for patients to come back in the hospital for acute heart failure. So there is really need to put together all these drugs. Now, in chronic coronary syndrome, we know very well that beta blockers are the standard of care, right? So I'm slowly to try to convince you that you should use also in patients without preserved ejection fraction heart failure and without preserved but with reduced heart failure as their evidence, but you can also think that beta blockers should be of great utility in many patients. I just would like to go very briefly, just 5 minutes more, because I think I put already in, let's say, into the table some, let's say, potential question. I would like to come a little bit on possibility to cooperation, right, with some patients that we need to better approach in acute heart failure, because it's there that we can obtain the better result. What is the reason? Because if the patient's coming back in acute heart failure, you can do a fantastic job, right? Because you can treat these patients adequately, you can restart his story in some way, right? It's the moment that you can optimize his situation and also, why not, to improve his outcome. And these are a couple of things that we should take in account. Of course, I want to try to remember that also in acute heart failure, to understand the reason of the disease, like in chronic heart failure, is crucial. It is really more important. I don't want to stress too much this concept. I just want to come back on the natriuretic peptides. I think that is something that you have really needed to understand, that we need to use as much as possible natriuretic peptides. And this is another scenario where we can contribute. What I can do, I can provide to you some company that are going to give for you periodically some testing for free that you can definitely contribute to collect the data to show and confirm your patient that you are properly using natriuretic peptides from the acute phase to discharge timing, to rehabilitation clinic, to monitor at home, to reduce the hospitalization, okay? This is another, I would like to address with you what you have not at the moment, but what you can achieve in next future, but we need publication, okay? We need to work collecting data. You need to show that this kind of utilization are going to be of value, reducing the patient's, let's say, mortality, hospitalization, but also reducing the cost, right? It is what we need to achieve. Okay. I just would like to address a little bit these questions of isotroponin, because during last meeting, right, some question came from you. How can I recognize the utilization of high-sensitivity troponin in patients with acute heart failure? I think that is really important to remember that in acute heart failure, high-sensitivity troponin is needed to identify acute coronary syndrome, but it's important to predict death. So I don't want to spend too much time to show that high-sensitivity troponin is mirroring myocyte cell death, and that the fact that the heart cannot regenerate, right? So having said that, so if you are going to have increased high-sensitivity troponin, mirroring that is going to have myocyte cell death, and means that the myocyte cannot regenerate, so you have fibrosis, and fibrosis is linked with the poor outcome. This is a crucial paper. My friend Frank Pickle showing this paper in New England, showing that in patients with heart failure that have no acute coronary syndrome, but have an increase in troponin level, mortality was much more in comparing patients with normal creatinine, normal troponin. And this is a paper we just published. Now the question is, that previous paper from my friend was using patients with reduced ejection fraction. And because reduced ejection fraction is linked with more myocyte cell death. But now, we think that is also true for preserved ejection fraction. So also in patients with acute heart failure and preserved ejection fraction, like we showed in this paper just published with one of my coworkers also, is very clear that in these patients, you should have increasing creatinine that is linked in the, sorry, I don't know why I say creatinine instead of troponin, increasing high-sensitivity troponin that's linked with mortality. And why I address that? Because I want you to participate on a study that is the Predict Heart Failure study that we are doing in the great network. Already we have 3 centers in Indonesia. I hope that you can participate. We have already have centers in Italy, in Czech Republic, in Brazil. So I would like to show the importance of measuring high-sensitivity troponin not only to rule out acute coronary syndrome, but to, let's say, able to make sure that some patients that are increasing high-sensitivity troponin are going to die. Somebody of you asked me, how can I distinguish between acute coronary syndrome, high-sensitivity troponin, acute heart failure, and patients with heart failure with increased high-sensitivity troponin? Very simple. You should simply apply for the guidelines. If the patients come in with high-sensitivity troponin very elevated, right, above the cutoff, is not acute heart failure, it's acute coronary syndrome, okay? Refer to CATLAB. And then you know that there is a lot of patients that are having some, let's say, value intermediate, right, between the low cutoff and the high cutoff. And this patient that they arrive, you have a value that is a little bit increased. Then the guidelines recommended to do the second shot between 1 hour and 2 hours, right? If within 1 hour, 2 hours, this level is still increased, but not ranging to the above the upper limit of cutoff as diagnosis, these are the patients that are not having acute coronary syndrome. They have acute heart failure with a high probability to die, okay? And this is really something that I would like to achieve with you because there's a lot of need to contribute the next guidelines, having a paper that I hope will be New England or Lancet showing that high-sensitivity troponin is an important tool to stratify the patient because we should start the hospitalization, let's say, prevention in the moment the patient is coming back. And this for, let's say, reduce, and which are the drugs that we can use? Probably beta blockers, because beta blockers are the drugs that can reduce catecholamines. You know that during acute heart or ACE inhibitor, but why not? Probably in a diabetic patients, we can use the SGLT2 inhibitor. So next step will be which are the drugs that I have to use in these patients to prevent the hospitalization, especially if the patients have preserved ejection fraction, right? Another area I would like you to contribute is congestion. Now in Yogyakarta, I really appreciate that the group of Yogyakarta was able to perform the first study in the world using a monoclonal antibody against bioadrenomedulin that is a biomarker of congestion, showing that it's very tolerated. So here you have the possibility in next future, if you like to contribute to evaluate the role of bioadrenomedulin, that is a biomarker of vascular integrity that is linked with the congestion. Because the reason of coming back is congestion, right? And you think that the patients, the congestion, you send at home, you do baby line, but the intracellular congestion is not able to be achieved, either not by NT-proBNP or BNP. So I just would like to conclude my presentation that there is a big link from acute and chronic. If you are doing very well in acute setting, optimize your treatment based on new tool of diagnosis that are based on high-sensitivity troponin and bioadrenomedulin, you can reduce the burden. So my proposal is to really make a kind of a bridge from acute phase to chronic phase to optimize treatment, don't stop beta blockers, insert as a GLT inhibitor, and measuring biomarkers. I just want to jump, I already presented this. Okay, we already discussed a little bit during our Saturday evening on the diuretic resistance. There is another opportunity I would like to work with you to provide for you some kidney biomarkers, I can ask a company. I know that one of your group cardiology already published a paper in Bengal. I can provide you some biomarker via predictor of diuretic resistance, such as Bengal. Let's work on that because this is something that we should really try to achieve, especially because you have not actually a transplant program, right? So you have a lot of serious patients that you cannot treat without with the transplant. I don't know. Yeah. This is another opportunity. Why I should have SGLT2 inhibitor? Because in this case, in acute heart failure patients, not anymore chronic, with both preserved and reduced ejection fraction, my friend Adrian Wars was able to show that if I start immediately epagliflozin 10 milligrams once a day, 3 days after admission, I'm going to reduce mortality with the patient's adherence. Because at the end of the day, it's very important also, it's very important to come with the patient's adherence. Coming here this morning, Dr. Nyoman showed me a fantastic WhatsApp chat of patients. You already have in mind some concept to monitoring patients, right? So I think we should work together to make your patient association contributing to their disease. And I think because what is the problem? Now you can optimize your patient's treatment, but I am sure that for many reasons, patient can stop the treatment, right? So you want to avoid they stop the treatment. You cannot ask the patient coming every week, right? So to telemonitoring the patients at home is the future. And in Italy, I'm a part of the government asked me to be part of the future of health system in heart failure. I'm very happy to be called by my country to contribute. How can we avoid patients coming back? And I say the first, but in Italy, we have all the drug, we have the technology, but I think we need to increase patients' adherence to treatment. And this is something you can do. So the doctor decide before discharge, okay? Call the nurses and say, monitoring the patient. You sent at home these 5 tools, saturimeter, EKG, bioimpedance weighting system, blood pressure, glucose testing, and then you have some green monitoring that is okay, yellow, be careful, red, that is bad, so you can immediately have a consultation and bring the patients at home, at the hospital from home in order to prevent relapse. This is really easy to do. It's not so, if I understand many patients are not familiar with the internet, there's something issue, but you can work with the caregivers, younger people, and especially the future is a way to reduce hospitalization. This is a way that I would like to share with you. I don't know if the video can go. I hope so. No. So we are going to send at home. Can you move the internet? So I'm sending at home nurses to make echocardiogram by artificial intelligence. So the nurse go at home of the patients. Okay, no worry. So he goes at home, he put the probe, and the cardiology from remote move the probe. Anyway, so this is a possibility also when the patient is at home, you can move the hospital at home, right? And it's a future that we can consider to use. No worry, no worry. If it's not possible, no problem. Now it's not coming. It's not going. Is it stop it? Okay. Could you go ahead? I don't want to take too much time. I would just to finish. Is there any possibility to go ahead? Okay, we can finish with that, no problem. I really would like to recommend monitoring natriuretic peptides. At the moment of discharge, you see that you have patients that are the mission has elevated BNP. Discharge BNP is more than 50% that I recommend is a target, okay? Don't discharge patients if their BNP reduction is less than 50%, okay? This is mandatory monitoring. Then, if you are controlling 1 month later, and TPRO-BNP and or BNP and the BNP is equal to discharge, no events are coming. If and TPRO-BNP or BNP is elevated without symptom, this patient will be admitted 1 month later, okay? So it is an early detection ongoing heart failure. So I think that, now rehabilitation, okay? I had the pleasure to work in San Diego with my friends, Pam Taub. She's a very smart woman from India, and she was able to show that if you are going to make an intensive rehabilitation clinic program, we are going to reduce the mortality and hospitalization. So rehabilitation is very important, okay? And I think we should work together to take some data, how much rehabilitation can reduce hospitalization. And this is what we have to achieve. Look at that. I think we would like to stress the concept that you want to really reduce as much as possible LDL cholesterol. And now we have a new drug that can do that. So there is a rehabilitation clinic and opportunity also to reduce hospitalization. I just would like to conclude. I'm very happy to be here. I see a lot of opportunity to contribute in a kind of improvement heart failure program with the final aim to reduce hospitalization. If we are able with our data to show that we can maintain more patients at home with heart failure, having biomarkers, ability to check biomarkers of myocyte cell death and congestion, to have biomarkers of kidney injury, and to have a new drug, to have a lot of technology, we can definitely convince your governors that they have to invest because they are going to have not only patients benefit, but reducing the cost. That is the problem in all countries, not only in Indonesia. Thank you so much. Terima kasih.
Thank you. Thank you so much, Prof. Salvatore. Please, you can sit next to me or to all cardiology residents, staff, Professor Wiryawan. Thank you very much for coming. If you have any question to discuss, share your patient, or maybe anything else you want to discuss this morning, please, I give you time to do that. Thank you.
Thank you, Professor Salvatore. Excellent talk like usual. So I'm very interested in the management or your advice outline on beta blockers. Here, we also try as much as possible to keep the beta blocker, cut the doses in half. But unfortunately, since we are a tertiary center here, a lot of patients came in at the worst condition possible with very low blood pressure. Quite often we have received patients that we need inotropes to get the urine out or get the fluid out. So how do you manage with inotropes for beta blockers, along with beta blockers?
Question. Beta selective beta blockers are not effective, the inotropes effect. So if you are going to use dobutamine, okay, that is the preferred drugs, this works a different way of the beta blocker. So there is no reason why, there is no competition between the two drugs because dopamine, inotropes are working both on alpha and beta receptor, while the selective, so I really suggest you selective beta blockers in the treatment. So definitely you can probably adjust the dosage, but I don't think that if you're a patient with very low blood pressure, taking beta blockers, the reduction of beta blockers is going to be favorably providing better effect of inotropes, okay? There are no evidence on that. What I can tell you, the effect of beta blockers in not only reducing the beta blocker efficacy, but there are a lot of resensitive of, let's say, the sensation of beta receptors that are made by beta blockers. And also, each myocyte is more relaxed, and so they can better receive the inotropic effect. So there are no evidence that using inotropes, there is a need for reduced beta blockers. And there are no evidence showing that. So the question is, there is no reason to think that if I use inotropes, there is any kind of negative balance of beta blockers, okay? So I think there is absolutely need. Of course, if the blood pressure is very low, you can probably reduce a little bit the dosage because of antihypertensive effect, but not because of the beta receptors efficacy. So I think in these patients, you should use inotropes, but you don't want to modify the treatment for heart failure. This is an important question that I think should be every day coming. At the end, these are very risky patients, I understand, but I see some effect also the kidney that are going to be efficacy without negative inotropic effect. So there are no evidence that beta blockers counteract negatively the inotropic effect of the drug. Okay, definitely we can have some experience, but let me tell you what I think. If you have a patient coming with a beta blocker with a very low blood pressure and you are going to give vasopressor, okay, and you are going to reduce beta blockers, there is no more beneficial effect of vasopressor. That means that there is a kind of a final reserve. These are patients you can probably in the future think about left ventricular assistance device, you can think of transplant, but definitely not reduce beta blockers.
Very interesting concept, and I think a lot of us will help.
Because to be honest, Professor, while I'm studying cardiology in Jakarta, maybe Dr. Junori and Dr. Putra is also my senior. My teacher,
I know,
maybe all of the teachers, yeah, right, told us that when you put the dopamine as inotrope, not only reduce, you must stop.
Oh my God.
Yeah,
I think
you remember Dr. Jun, Dr. Putra?
Yes,
Yes.
because obviously we read the textbook, as you say, there's no evidence that it's contradictory, but there's also no evidence that it's beneficial.
Yeah.
So
Yeah,
If we're still using the beta blockers, then maybe 2 hours more, and then we call it to the day room, and then wow.
no, this is a challenging. I really,
Yeah.
I told already, it's a very challenging question. Let's try to making scientifically. The efficacy of beta blockers in heart failure are not linked to their inotropic effect, right? They are linked to resynchronization, resensitivity of beta receptor. They are working on a kind of, let's say, the extension of single myocyte because of a beta blocker that is not negatively affect the response. So these are two mechanisms that are not coming in the same. Of course, empiric medicine is always important, right? But we are moving on evidence-based medicine. As you said, probably we can do a trial, but all guidelines are recommending not to stop beta blockers into the acute phase. And this does mean, as a consequence, that you can use any kind of drug containing beta blockers. Probably again, you can have a little bit of reduction of dose because blood pressure should be too low. That's probably possible. But again, probably we need a study, but this will be a multi-study study. From my personal experience of several, this is the same reason why, in the past, people were thinking, oh, beta blocker I cannot use in heart failure because it has negative inotropic effect. It's a stupid consequence. Sorry to say that, right? Because there is very evidence that the efficacy of beta blockers in heart failure is not linked to their inotropic effect, but more with other effects. And then also, inotropes are working more on the kidney function than on the heart. So, and of course, blood pressure could be an issue. Blood pressure, you want to reduce a little bit because if you want to reduce beta blocker because blood pressure is very low, that is another story. But not because you are going to reduce the efficacy of inotropes, okay? That's something that probably needs a bigger trial.
Yeah, because it's interesting. To be honest though, anecdotally, we've seen patients that, very bad low pressure, start inotropes, but along the way, the physician or the nurses forget to stop the beta blocker. So we find out the next day that, the beta blocker is still given, but the effect of the inotropes is still going. It's still there. So that is actually an interesting concept, and I think I can agree with that. Thank you.
Yeah, especially in heart failure reduce, it's already done. The evidence based for beta blockers in heart failure reduce is for let's say that more than 30% to reduce rehospitalization and cardiovascular death or mortality.
Yeah, I have another positive.
Yes.
Okay, so this means that now all patients are taking beta blockers. Now the question is, if the patient's coming with a very severe heart failure, how much beta blockers should be used? I can tell you that for blood pressure, also reducing ACE inhibitor or 18-1 blocker could be beneficial, right? Why you want to reduce beta blockers? And also, that is an important message I want to conclude. I mean, at least contribute. Sympathetic overactivity in acute heart failure is important, is huge. So if you reduce beta blockers, the sympathetic activity is going to not contract anymore. And the same for angiotensin aldosterone system. So this means that probably you should even increase a little bit the dose of beta blockers or ACE inhibitors in the early phase. So I just want to say that in acute heart failure, the neurohormonal activity is so huge, both from sympathetic activity and also angiotensin aldosterone system, that you don't want to stop drugs that are counteracted this to, let's say, neurohormonal activity. Of course, I think that is a kind of war that we have to try to solve, but I am too much biased with the beta blockers, right? I have so much experience that, to be honest, anecdotally, you can do whatever you want, but you cannot, when you use anecdotally, it's for young people, you never know if the reason was exactly that one, right? How can you say that that was the reason of the patient's improvement, right? We need to take 20,000 patients, acute heart failure with low blood pressure, taking beta blockers, vasopressor, against 20 patients and see the mortality. But there is no person will make this story because we are too much convinced that the beta blockers you cannot stop.
And regarding the beta blockers using in heart failure, especially in heart failure reduce, many of our patients also have the high hemoglobin level is lower. Maybe then we should, we already, what a physiology response to anemia is usually higher heart rate. Do we stop also the beta blocker? But according to you said that once I already found in my cardiac resident, once then that they are present in anemia, we should stop the beta blockers.
Oh my God.
Why? I also
God.
them why.
Makes no sense again.
Because they said that this is the response of physiological response to get higher heart rate.
Okay.
So we should not stop the physiological response. What do you think, Prof?
Okay, that's a very good question again. First of all, one thing that I always say my residents or my co-workers when they see anemia in acute heart failure, I ask the kidney. The problem is many patients are, not evaluated for the kidney because kidney dysfunction is always linked with low erythropoietin production, right? So many of these patients can benefit of erythropoietin that is going to be ameliorating the let's say hemoglobin availability. So first of all, check for the kidney. And I really think that there are many papers and also in the guidelines suggest that you can have now the injection of a ferro inject, right? Do you have this drug in Indonesia? We inject ferrum, IV.
Yes. IV and also erythroprotein also.
Yes, erythroprotein for if the patient has a kidney disease.
Yes.
The question is you should not measure hemoglobin, but say you should measure ferritin, right? So that's the issue. So I suggest before jumping to stop beta blockers, there are so many things to do, such as controlling ferritin, controlling a kidney function that are going to solve the problem. That makes no sense to stop beta blockers again. Because just give me one physiopathological mechanism that justify to stop beta blockers in this kind of patients. Just one reason. No, just one reason. There is no reason, right? Because many times we do something that we are not understanding why the hemoglobin is low. Is that something that is dependent of the fact that you need to increase their ferritin? Is the fact majority of these patients, they have a kidney disease. So, erythropoietin infusion or submission is needed if your hemoglobin in heart failure is below 9. Okay, so think about this relationship with the kidney dysfunction and the erythropoietin low, and then you can have a benefit. So I don't see any benefit in the suspicion of beta blockers. So there are, I understand that is a tough, let's say, topic, but trust me, anecdotally or not anecdotally, there is really no evidence scientifically that the suspicion that to stop beta blockers is improving our patient outcome with anemia or very low blood pressure.
Okay.
Is
Nice.
anyway to be a room? Yeah, should be. Why don't you make a case, right? Case report and publish a case report, but you were measuring catecholamines level. You want to measuring all the things and say, okay, this was really because of beta. And do you want to measuring circulating level of the drug? There are so many things that are needed to come to a conclusion that reducing beta blockers, you are reducing the catecholamines efficacy. So a lot of things that actually are not available. Probably you can tell me I'm so much biased with the beta blockers, but I can tell you I don't see any scientific evidence to stop beta block. I hope that was at least able to open your mind differently, okay?
Yes, it's very open mind and open eye. Actually, Prof. Okay. From the cardiology resident, because your headmaster is already asked the question, maybe your cardiology resident.
Hope you don't want to stop beta blocker, please.
Thank you, Prof. Salvatore, for the excellent presentation. I want to ask about your comment about how to initiate angiotensin neprilysin inhibitor in the outpatient setting, especially in the heart failure with reduced ejection fraction, where the patient come with the hypotensive condition, and therefore they cannot tolerate the side effect of the medication that end up that stopping medication, and then will end in the recurrence hospitalization. I would like to see maybe your insight to us about what you can advise you can give to us. Thank you.
So again, an excellent.
Yes.
Okay. So your question, I can agree with you that sometimes you should reduce ACE inhibitor in these patients. So I think that makes more sense. If your question is patients come with very low blood pressure, right? In acute heart failure, right? Taking ACE inhibitor or let's say drugs that are going to affect the blood pressure, right? I think that's the case that I would like to stop or reduce as much as possible ACE inhibitor. And you can tell me, but then is a little bit controversial what I said before, that also neuronormal activity is going to be reactivated. But in this case, you can adjust anti-aldosterone drugs, okay, such as eplerenone or aldactone, okay, or spironolactone. So I suggest that in this case, it makes more sense to reduce as much as possible AT1 blockers or ACE inhibitor and increase anti-aldosterone drug. in order to have a, let's say, negative effect on blood pressure. So if your question was, should I reduce ACE inhibitor or 81 blockers in the case very low pressure in acute phase? I think yes, that makes more sense than the beta blockers. I don't know if I address your question.
Yes, thank you, Prof. And for the if the setting, if after we discharge the
Oh.
patient, and then in the outpatient setting,
That's a good point. That's a good point. I think that before discharge, you should reoptimize the treatment, right? So of course, in acute phase, you have to adjust something. The problem is in this country, you have not SGLT2 inhibitor, right? That we show to be. I think that you have to lead with the blood pressure, right? And the kidney again. So I think that you should try to adjust the ACE inhibitor, and you should probably think about adequate the dosage or shift to Entresto, right? But Entresto has also some additional effect of blood pressure. So it's a situation that you want to go case by case on the titration of the drug, watching blood pressure. This is the benefit of SGLT2 inhibitor, right? They have one dosage, just 10 milligram, while the other you have to adjust. So there is an opportunity in this patient to adjust the dose, because sometimes ACE inhibitor or 81 blocker are used in high dosage, right? That I don't see the value. I think very low dosage of ACE inhibitor or 81 blockers are enough.
Okay, thank you, Professor.
thank you, Prof.
Is there any question? For one more question, because after this, the professor would like to see our dean in our campus in Sudirman. Anyone wants to?
Yeah, over there.
Good morning, Prof, and good morning, Dr. Nyoman. Thank you for the opportunity. My name is Alif. I want to ask two questions, Prof. The first one is about SGLT2 inhibitor.
Yeah.
The first one is about SGLT2 inhibitor. As we know that we have no doubt in the use of SGLT2 inhibitor in HF patient, but is in the future, Prof, is SGLT2 inhibitor only can be used in HF-related patient. As we know that SGLT2 inhibitor have many effects, not only on remodeling, but also several other effects. Can we use this kind of drug, this SGLT2 inhibitor, in other cardiovascular disease-related disease other than HF, other than heart failure, such as myocardial infarction, post-PCI, or other cardiovascular disease? Because maybe in a couple of years, this drug will be inside our national health coverage drugs. One of inside of our national health coverage drug. So can we use it, or there is some trial that ongoing about the use of SGLT2 inhibitor outside heart failure disease? And my second question is about Quest trial, the new trial in herbal medicine, Chinese herbal medicine in HF patient, the Quest trial, Prof. What is your opinion about this trial on the use of Chinese herbal medicine in HF patient? On the use, check, 1, 2, 3, check, hello? On the use of Chinese herbal medicine, Quest trial on heart failure patient. Thank you.
Yeah. Your hypothesis that this kind of drug as SGLT2 inhibitor have so many favorable effects that should be also used outside heart failure with other diseases such as hypertension, right?
Yes, that's right.
There is no doubt. There is room for this drug to be used. For instance, I see a lot of value in patients with hypertension and diabetes to control both diabetes and hypertension with this drug. So this already there. So the only, let's say, possible side effect of a SGLT2 inhibitor in heart failure is hypertension, right? because there is something that all the drug with the heart failure should be treated. So for definitely, I have already an answer. If you have a patient with hypertension that is not really so elevated, or if you want to optimize, let's say, your antihypertensive treatment, and he has diabetes, I see the value of SGL inhibitor to optimize the treatment. You don't need the trial for that. It's something that is already there, right? Your question is also related to the fact that you can definitely also use this drug in acute coronary syndrome, right? And I think that if the patient with acute coronary syndrome, he has hypertension, that sometimes is also there, that makes sense, right? And I'm sure that once we are going to analyze the subgroups of data from the trial, both preserved and reduced ejection fraction, it will come out that patients with hypertension can have the better outcome. So definitely my my answer to your question is in hypertensive patients, especially with diabetes, with coronary chronic heart disease or hypertension, there is room for use of this drug to optimize antihypertension. So let me make very simple. You have a patient with blood pressure 145 or 95, okay? Naive of antihypertensive drug with diabetes. Why don't you are going to take the advantage to use this SGL inhibitor to control both? Definitely, for other disease is possible, but we need a trial. But I think that actually for hypertension, you don't need a trial. For acute coronary syndrome, you need a trial probably in patients with hypertension, okay, to optimize. But we know very well that all the guidelines, they recommend to treat the underlying reason of the disease. Huh? So I think that SGL inhibitor, we don't know exactly the mechanism of action. Is endothelial protections, is vasculature protections. I think that final goal is the kidney, right? Where they are increasing the glucose excretion, and the glucose excretion is always linked with optimized blood pressure, with a lot of beneficial on the vasculature. So there are a lot of, let's say, ancillary effect of this that I see a lot of potential utilization also outside heart failure. I don't know if I address your question. The second question was about Chinese. Oh, that's terrible. Really, these people are crazy. I mean, I have been in Taiwan, right? And they use a lot of these are very dangerous drugs. They are going to have a lot of toxicology on the liver and on the kidney. So Chinese should be controlled what they are doing. I'm sorry to say that, but they cannot do whatever they want, right? They have to understand they are into a general war. They should. So I really think that is a crazy idea.
Okay. Thank you so much, Prof.
I don't know what you think, but I don't think that is really room. We will never in our society will accept this kind of concept. It's based. If the Chinese are going to make a big trial, but I will never participate in this trial, okay? I will never give my consent. Are enrolling 40,000 patients with their treatment. I don't know. In China, they can fund these patients. But no, I know, I don't see the value. I don't want to take the risk of take a drug that has so many negative concomitant effects to show something that I already achieved with the drugs that are well controlled. So the problem of Chinese, they should be better controlled in what they're doing in science. So just to be shortly my conclusion. No, I will never accept my consent to take this kind of pills.
Okay.
I'm sorry to, I don't want, I mean, hurt any Chinese guy, but it's my position.
Okay.
Okay. Thank you so much, Prof. and Dr.
Thank
Nyoman.
you. Thank you, Dr. Alif. Thank you, Professor, for your answer. And there is one question from Dr. Chendra. I heard from
Please.
Dr. Chi. Dr. Vidya said Dr. Chi wants to ask the question.
To him a microphone. He wants a microphone.
Oh, online? This is the hybrid. So once is
online.
online.
Yeah, sure.
Hello.
Yeah.
Hello, Professor.
Hello.
Hello. Okay. My name is Cindy. So I want to ask about your opinion with the chronic heart failure patient. Since the patient routinely... Hello? Can you hear me?
Yes.
Yes.
and
Yeah. So I want to ask your opinion about the chronic heart failure patient. The patient routinely already using the diuretic since a long time. So I want to know about the balancing of the fluid with the treatment of the diuretic, since the patient sometimes came with the dehydration. So we can see from the slightly increasing of the renal function. Okay, thank you.
Can you repeat again the question, Dr. Cindy? Do you want to know?
So I want to know about the opinion about the balancing the fluid with the diuretic treatment in the chronic heart failure patient. Can as we know that the patient already in the diuretic so long time. So can you hear
So
me?
I can repeat the question to make sure that I understood, okay?
Okay.
So patients coming with acute heart failure.
No, with the yeah, okay.
No, sorry, there is a little bit of confusion. Sorry, could you slowly repeat the question? Could you please a little bit listen to it? Could you please repeat the question? Sorry, I really apologize.
Okay, it's fine, it's fine. So I have the patient before with the chronic heart failure. The patient routinely already in diuretic with so long time. So the patient came with the slightly increasing of the renal function. Sometimes the patient came with the dehydration. So how your opinion about the balancing with the fluid and the treatment with the diuretic? So what's your opinion with the patient?
Okay, that's very important. So we are talking about cardiorenal syndrome type 2. So chronic heart failure and kidney dysfunction, correct? So patients coming in your office with the diuretic treatment and the deterioration of creatinine, correct?
Correct, Prof. Correct.
So this means that this patient is dehydrated. So this means that this patient is taking too much diuretic. It's very clear that you want to try to adjust and reduce the diuretic dosage. I have a good suggestion for you. You are lucky today. Don't check only creatinine, check urea. Because if urea is elevated, in this case, you are going to reduce the diuretic and you are increasing the, let's say, the water intake. You can even give infusion. And in one day, your urea is coming normal. This was a confirmation that was dehydration. So in these patients, don't check only creatinine, check urea, where you can normalize urea or decrease urea if you are reducing diuretic and increasing the fluid. So this is the confirmation that was dehydration. Is that clear? To her.
Clear, Prof. How about the balancing with the fluid?
The weight?
The fluid in the chronic patient.
Okay. In this case, you simply ask the patients to drink more water and reduce diuretic for a couple of days, right? Very simple. You don't need to admit these patients. You can solve the patients, asking the patient to reduce or stop diuretic for 2 days, but you have to control urea again, okay? So don't follow creatinine in this case. Just trust urea. I don't know if so. Just give ask him to drink more and stop diuretic for a couple of days. But check urea. You want to be confirmed that urea is coming normal again, and then you can adjust your diuretic dose, because this occurs many times that people are overtreated with diuretic in chronic phase. Is that did I answer your question?
Okay, thank you, Professor.
Okay.
Okay, thank you very much, Professor. Also for Dr. Cindy, Professor, and we already see the guidelines that the loop diuretics is class 1 indication for fluid retention. Remember, cardiology residents, fluid retention. So we must understand that diuretics, especially in the guidelines said that loop diuretic, if the patient come with symptom and sign of fluid retention, fluid overload, so diuretic is must. But if there's euvolemia, diuretic is not a class 1 indication. Is that right, Prof?
Yes. So
diuretic is not a 4 pillars of heart failure treatment, usually in heart failure reduced ejection fraction. Remember that diuretic is not a God's drugs. We call it here the obat dewa, Prof. So
no, this is an important topic, and also the reason to implement the utilization of SGLT2 inhibitor, because they also have diuretic efficacy, right? And also diuretic can increase glycemia in some way in diabetes. So it's absolutely reasonable that we have rethinking if we can use SGLT2 inhibitor. I don't want to make sure that you won't just exclude, but rethinking about the dosage of diuretic, because SGLT2 inhibitor, they have diuretic effect that is beneficial for the kidney and also for the disease. I think that is something that we should take in account. And now these new bioadrenomedulin biomarkers that is reflecting very clear the intracellular congestion should be a target for diuretic treatment. In order to optimize our diuretic dosage, we can measure the bioadrenomedulin. The normal value in patients is below 35. Okay, so if the patient is below 35, you probably can stop the diuretic. So the future is no, we should use the biomarkers that IMFAN, you know very well, in order to make a therapeutical decision. Okay. You want a biomarker that's going to give you some therapeutical decision. In order to have therapeutic decision, you want to understand what this biomarkers is telling you, right? What is the physiopathological mechanism that is going to make the increase of biomarkers? High-sensitive troponin means myocyte cell death, okay? And TPO-BNP or BNP means volume or pressure overload, right? Bioadrenomedulin means intracellular congestion. And I think these are the way in the future. And of course, the last biomarker, we need the kidney damage biomarkers. We still have a creatinine. Creatinine is a fantastic, let me make a kind of a syllogism between kidney and heart. High-sensitive troponin and natriuretic peptide are both of utility, mirroring two different physiopathological mechanisms. One is function and TPO-BNP, and one is damage, high-sensitive troponin. Creatinine is a functional biomarker, right? We need a tubular damage biomarker that is going to couple with the creatinine. So we are not going to replace creatinine or urea. We need some tubular damage biomarker that, so at the end of the day, we need that biomarker that is a troponin of the kidney. And NGAL will be one of these.
yeah, that is interesting, Professor, because last night, Dr. Satri has already asked a question about diuretic resistance. So this morning, I also asked you a question, how we can predict or maybe how we can see the early sign of renal damage related to maybe before diuretic resistance came.
Just coming back on the nice question the person online was taking out. At the moment, you can just make urea as, let's say, empirical solution. in the future, in these patients, I can do acute kidney biomarker to see if this creatinine is linked with some damage of tubular, so I can optimize after diuretic treatment, right? And do something probably more ACE inhibitor or more SGLT2 inhibitor that are. So we need now to optimize tailoring our patients' treatment based on these biomarkers and the many drugs that we have. So there is a room now to optimize personalized treatment based on using these kind of drugs adequately that are probably different patients by patients.
Yes. Okay. Professor, I'm sorry to share that our dean at 10 o'clock.
Okay.
No, at 10 o'clock is will have to attend the doctoral
Final inauguration.
Yeah,
Doctoral.
final inauguration. Husband of Dr. Rani that was already sent you email about NGAL thesis. So, but the dean said that at 12 o'clock he is ready to meet us. Yeah.
Okay.
So because if we come to campus right now, there's only a limited time to see the dean. Should we wait until 12 o'clock? So move to the Dr. Melissa and
It's up
Dr.
to you.
Oliva.
Yes, let's move the appointment with dinner at 12 o'clock. It's okay?
Yes.
Okay.
It is fine for you?
Absolutely.
Okay.
You are my owner.
So can I follow up on your question then? Since you're you like beta blockers so much. Now, what is your experience on preserved ejection fraction? For preserved ejection fraction, we know that until before SGLT, we don't really know what to give.
Yeah. So I think that there is again a need for more evidence that in preserved ejection fraction patients, we can use so your question is, if I have a patient with preserved ejection fraction, should I use beta blockers
Yes.
instead of SGLT2 inhibitor?
Yes. Yeah. What's your experience? Because a lot of us here, because we don't know what to do or give in this patient, before we usually just trial them with beta blockers.
No. This is a good point. We had a debate 2 years ago to European Society Heart Failure Association just on this question, right? Guidelines, they recommend in the case of heart failure with the preserved ejection fraction to check for the reason of heart failure. And more frequently, these patients has hypertension. So you are going to give beta blockers for hypertension. That is my preferred drug because they have a lot of, let's say, concomitant beneficial effect. You can give beta blockers because they have atrial fibrillation. You can give beta blockers because they have a coronary chronic heart disease. So the reason to give beta blockers in preserved ejection fraction is not linked to the evidence they are going to impact their outcome in terms of mortality hospitalization. But you can follow guidelines because you are treating the concomitant disease. So definitely, I cannot say that in patients with preserved ejection fraction, beta blocker is a recommended drug because you have no evidence, right? There are no trials such as it, but if the patient has hypertension or atrial fibrillation or coronary artery disease, so you have to treat the underlying disease, makes sense to treat the patients in this sense with the beta blockers.
Do you usually check them or make the decision on the beta blocker based on their heart rate? Are you familiar with the MyPace trial that just came out? Yeah.
That's a very important point. Of course, if the patient has hypertension, I don't care about heart rate. So at the end of the day, if you are going to start, we are talking about patients with heart failure, right? So if the patient has hypertension, I treat hypertension, I give the doses for hypertension. I'm not giving, of course, if the patient has kidney damage, I would like to titrate based on the kidney. If you have a drug such as atenolol, you have atenolol in this country? No, you have not atenolol. So there are different metabolic excretion from the beta blockers. Some one are more excreted by the liver, some other from the kidney, right? So you have to adjust the dosage of the kidney, but you have to use the dosage for hypertension. In hypertension, you don't need to titrate. In other fibrillation, you need to titrate a little bit. In coronary artery disease, you don't need to titrate. So I don't see the reason why. In the preserved ejection fraction, I don't see the reason to make this increase dosage based on rate response. And another important message: don't stop beta blockers because heart rate is too low. Please. There is really a question if some cardiologists, they see heart rate below 50, they stop beta blockers, right? I don't see the reason. You are electrophysiology. Why, if I am sinus right, if I am okay, why I have to stop beta blocker reduce, right?
Yeah, I should put in a pacemaker.
If you are kidding me, right? But because if the sinus right is there, I take beta blocker. My heart rate is 50. I'm so happy. I'm living very well. I'm reducing my oxygen consumption. That's what I want. Elephant, they live longer than mice. Elephant heart rate is 42, 43. So, of course, I think that you can say that I live too much of fan of beta blockers, but I think that beta blocker can expand life expectancy for many reasons.
But well, I'm not fully kidding, right? I think the guideline also allow us to do that. If the very slow heart rate is inhibiting our giving the patient beta blockers, there is an option, a class 2B recommendation. You could consider pacing just to keep the heart rate low, but enable the administration of beta blockers. Right?
But you are talking about heart failure.
Yes, not for hypertension. Sorry,
right?
Not for hypertension.
In heart failure, I agree with you. So if it's heart failure, you can consider the heart rate as, let's say, a kind of limitation. But outside heart failure, hypertension, coronary artery disease, is always a kind of reduction of oxygen consumption that you want to obtain. For heart failure, I agree with you. So we talk about heart failure, heart rate should be considered as a problem to manage the dosage. And that's what guidelines recommend.
Yes.
But outside heart failure, there is no reason.
Yeah. And how about your opinion, Professor? Do you need to use, while using beta blocker, which one is our target? Heart rate or dose?
In heart failure?
Yes.
I don't think the heart rate is a target. I mean, in some way, you don't need to reduce too much heart rate in order to have the figure. You just want to have let's say start with the low dosage.
Yes.
If you have 20% of heart rate reduction, you'll be happy. You don't really want to come very low heart rate in heart failure, right?
Yes.
So I think that if you start bisoprolol 2.5 milligram or carvedilol 6.5 milligram, and you obtain some reduction heart rate, is already enough.
Oh.
You don't want to reach very low heart rate in heart failure.
Yeah, maybe like you said that, your slide said that maximum tolerated dose maybe it happened to this patient.
Exactly. So in heart failure, we are talking about reduced ejection fraction, right?
Yeah.
In heart failure, I think that you should be happy if you just reduce heart rate a little bit. You don't want to make bradycardia. You don't need to reduce too much. You really want to have efficacy, to have 20% of heart rate reduction, and it's well tolerated, right? Also, the patient tolerability is important. You are okay. You don't need to increase too much. Or if you are going to increase a little bit and the heart rate is still okay, you can still test.
Okay, we have still time. Is anyone wants to ask a question, Dr. Asman? Yeah.
Okay, thank you, Professor, for your great lecture to our department. My name is Hasman. I just want to ask questions about your presentations. You say that don't stop beta blocker because the patient will be die. But sometimes we find the patients with very hard to
get a good heart rate because of the beta blocker. They is very intolerant because of the beta blocker. How about using another kind like chemotherapy for the kind of patient? Actually, this is not an affair. Of course, this is not a affair relation. But how if you can use chemotherapy for the patient?
No.
Second patient. The patient before about initiate ACE inhibitor in patient after stopping or moving process. How if patient is not with ACE inhibitor because they didn't tolerate trial to actually really have much condition in this Indonesia, but they use it parts or how about we is it okay if we change the medication or we reduce the dose about the condition?
Okay. No. They are both very good questions. On ibabradine, let me tell you that they recommend in the heart failure recommendation is not so high, right? It's not evidence 1A, is very low. Because the evidence are with the patients already treated with the beta blockers. So in the heart failure, you should add ibabradine to beta blockers to optimize the treatment. I think that makes no sense because, yeah, I can probably, if I want to modulate the sympathetic activity, I can probably use ibabradine instead of beta blocker, but there are no evidence of study because the study are coupling ibabradine with the beta blockers, right? So I still suggest that you, before making this utilization of ibabradine, could you try to optimize beta blocker treatment, right? Because there are not so supporting evidence that ibabradine can be replacing. Because your question, should I replace? You know what's happening? Many cardiologists are using ibabradine in coronary artery disease. That makes no evidence, right? To be honest, I don't use so much ibabradine. Probably because I prefer to, let's say, tailoring dosage beta block. I cannot exclude that some patients can benefit, but there is no evidence in this sense. You can do, but there is, you can do whatever you want, right? But there is no supporting evidence from the literature. The second question is a very good question. I think that when you are going to introduce ACE inhibitor in heart failure, you always should consider if the patient is taking diuretics. Because the negative effect of ACE inhibitors very frequently is linked with the diuretic use. So first thing I suggest when you have to start ACE inhibitor, is the patient already taking loop diuretic plus anti-aldosterone drug? First thing, try to, and then after that, if taking diuretic, I suggest to start not very high dosage of ACE inhibitor or AT1 blocker, right? So I think that the difference on the dosage, depending if the patient is on diuretic or not. If he's on diuretic, especially if he's in both loop diuretic plus anti-aldosterone, I think you can start with a very low dosage and you are happy, right? If the patient is not taking diuretic, you can probably give a little bit more dosage. Did I answer your question? So how much I can start? And my answer is depending on diuretic dosage. Is that okay? You want to start direct with Arnie? Yes. I think you can, considering the same limitation of ACE inhibitor, I don't see any difference between the two. To be honest, I don't see why Arnie should be different from ACE inhibitor. There are no, at the end of the day, they are similar mechanism of action. So I think you can start with ACE inhibitor again. So let's try to optimize, first of all, what we have, right? Before thinking to spend more money for something. That is a good, that's good in Indonesia that you have not the possibility to jump immediately to no innovation. there are a lot of room to optimize what we have in our daily practice.
Some a crazy conclusion. Instead of we are using ARNI, that is quite expensive. Even the ARNI is already available in national coverage. In the heart failure reduction, reduced ejection fraction, we use ACE inhibitor as the lowest or cheaper one, and adding SGLT2 inhibitor. Even SGLT2 inhibitor not in national coverage. What do you think, Professor?
So your question is, should I have many different ACE inhibitor?
No, what I mean is ACE inhibitor is widely available here in Indonesia. ARNI is not.
Right.
Even is ARNI is already in a national coverage, but SGLT inhibitor is not in a national coverage. Instead of they are using ARNI and getting much cost.
So let me understand. In Indonesia, you can prescribe ARNI without prescribing ACE inhibitor?
Yes.
So why you want to start with ARNI and not with ACE inhibitor?
That is what I meant. Yeah, in Indonesia there is a restriction, Prof. We can use ARNI after we use ACE inhibitor and ARBs, and there is a symptom and signs of heart failure that it cannot tolerate.
Yeah, of course. This makes sense. This was guidelines recommend. So if you have a patient that is not well treated with the ACE inhibitor, you have the reason to shift to ARNI. There is no debate. I don't see the situation and you want to start with ARNI. His question was, I have a patient that I have to restart. Should I restart with ARNI? I say, why? You know, you have to use ARNI if your patient is intolerating or not well tolerated by ACE inhibitor. So that is my, so you should use ARNI, but only if ACE inhibitor is proven to be not effective. As hypertension per se is not a reason because ARNI are also giving hypertension.
Maybe his question is based on the American guidelines that ARNI / ACE. In European guideline, ARNI / ACE ARNI. That is maybe his question based on that.
I think that there is a lot of need to shift from ACE inhibitor to ARNI. I don't see the opposite, right? I don't see the reason why I have to start with ARNI. That's my situation. I have to follow the guidelines. They say if the patient is intolerant or not well controlled by ACE inhibitor, you should do ARNI. That's, I'm a European, so I prefer following. But I don't want to say that Americans are I mean, wrong, but I think that there is more sense in terms of a cost, right? Yeah. Because the problem is if you have a public system or you have a private system. In America, you have a private system, you can do whatever you want, right? You just pay. In Europe, we want to make, and this makes sense, right? Because we pay for the drugs, we want to make sure that the drugs are adequate. And I think in Indonesia, you have the same approach, probably too much restrictive, but at the end of the day, the approach is the same, to make sure that the doctors are using what is a based evidence. That is what we need, right?
Professor, is there anyone here to make a question, please? Yeah.
Oh, yes.
Dr. Utami? No.
Thank you, Prof. Salvatore, for your kindly presentation. I have one question. Come back to the beta blocker use because I have bad experience for patient. I initiate the beta blocker for the naive patient with acute heart failure. Patient with the reduced ejection fraction about 27% with the EF, And after I check this patient with the euvolemia, with the ERAP not 15, and the B-line are disappeared. And I give this patient with the bisoprolol 1.25. And then I give them at the 12 a.m. At the 8 p.m. He become acute lung edema. And this is happened for 2 patients, and the 2 patients were passed away after that. Can you give us tips and tricks for the initiation of the beta blocker in the naive patient?
That's a very good point. What you did correctly, because following guidelines, they say when the patient is stable, is decongested, you can start beta blocker, right, with the low dosage. But I have you had 2 experience where you did this based on your clinical practice and the patient get worsening. First of all, I always start with the carvedilol and not with the bisoprolol, very low dosage, because this alpha blocker activity is also to be of a more favorable effect compared to beta blocker per se. So carvedilol, you have carvedilol here, right? Low dosage of carvedilol should be preferred, but you can tell me that there are no difference. A little bit of difference in mechanism of action is there. Now, like we discussed already Saturday, B lines are mirroring kind of decongestion in the lung that are also almost equivalent to decongestion into the peripheral edema, but are not mirroring the intracellular congestion. So at the moment, I suppose that the guidelines are not adequately recommending how to measure congestion, right? So B lines is a good way, but it's still empiric, okay? You can quantify B lines, but you have to follow my paper showing that you have to, what is the problem of B lines? That is operator depending, is not a biomarker. You know what I mean? So I can argue that that patient was not decongested, because if you go to another resident, they do B lines better than you. Okay, that is the question. And the third question is, what about the kidney? Was the kidney normal functioning? No, right? So this means that congestion was there, right? So I assume that the patients you mentioned is a typical practical patient, but I don't want to say, I cannot jump to the conclusion that the bad response because it was beta blocker per se. I suppose that that patient was not totally decongested. I suppose that in these patients, I always prefer alpha and beta blockers, carvedilol, both than bisoprolol. I cannot, let's say, conclude that you did wrong, but the guidelines, they say something that make us life very difficult, because they don't tell you which are the criteria to stabilization and decongestion, right? And the B lines is very empiric again. Although is something is better to do than not to better do. Because the question is, when you checked the B line by ultrasound, you were the person that were doing the admission B line, and the second time, or was another residence?
We routinely check the B lines at the morning for patient with the acute heart failure until he discharged from the...
The same residents do?
Maybe no.
No.
That's the issue, right? That's the problem of B lines. And that's the reason why we published that paper. You have to, what you can do? You can do a journal club. I recommend you do a journal club. Every 4 weeks, make a journal club. Take one paper. Take my paper on B line and make sure that everyone is making B line check. Say, what's the problem we have with B line? We have to standardize. Our paper was just to make sure that all the residents make the same beeline check, right? You need guidelines also for beeline. I don't know if it is, but I recommend you to do really every 4 weeks a journal club. Just take a paper, discuss on that paper, and see how you can standardize the beeline. That is also, I think, as a chief of the resident, you should consider the journal club. That is, you already do. Okay, but probably, you know, that will be something that is for them to utilize the same. Beeline is an important issue because I have the same problem. Many residents are very good in ultrasound, others are less good.
Thank you, Professor. Dr. Utami.
So just to conclude, I cannot say that beta blockers sometimes should be evaluated in acute phase. I don't want to say that, but I wanted to make sure that we are going to say that beta blocker is detrimental for the patients, having more evidence that at the moment we have not, right? So jump that conclusion, because the guidelines say that you know, you should give, and the problem is they are not quite precise. How can I monitoring congestion? Bioadrenomelanin should be a solution in the future because congestion is difficult to assess. We discharge many patients at home. We think they are decongested. We don't check NT-proBNP. What do? We check legs. We check rails, right? We do beelines. Congestion is still there, especially if the patient has kidney damage. And the congestion is the first reason for patients coming back. It's the first reason. So we discharge many patients that are still congested. That is my hypothesis. That is probably, but it's not only Indonesia, it's worldwide. So we should have some way to measure more accurately congestion, and bioadrenomelanin should be solution, at least NT-proBNP and beeline together, right? At least.
Thank you, Professor. This is
Yes, another question.
All right, so still continuing the discussion. I don't know if you have adequate or a lot of experience with Asian patients, or especially East Asian patients, because that's also slightly different. Now, since my cardiology training, we've always been told, and to be honest, clinically, I saw that as well, that our population here, tolerance to beta blocker is significantly lower than what would the European or Caucasian population. For example, my patients with 10 milligram of bisoprolol, I can count them with fingers, that I have patients that can tolerate that dosage. So going back to the residents' questions, I think your idea of using the carfentanil, because it is available in a much lower dose that we can initiate really low. Meanwhile, for bisoprolol 1.25, we consider as low, but probably not low enough for our population, because similar cases, I've seen that happen as well. And with carfentanil, I think it's a better idea.
I mean, fully agree with you, 100%. We need more data from your population. So that's the reason why I really insist that we are going to, let's say, collect more data in your population. Because I assume that the dosage of some drug that be recommended of guidelines are based on the very low percentage of Asian population. So I really agree that probably the dosage that we are recommended for European population of beta blocker is higher on the tolerability. Probably sympathetic activity is a little bit low. We know that, for instance, in Black people, the dosage of beta blocker is needed more higher, right? So I cannot exclude that you're right. But this is a reason to collect more data. And why don't we take 20 patients coming in the acute heart failure, dosage norepinephrine content, dosage some circulating. If the dosage of bisoprolol 1.25 milligram is circulating higher level was needed, means that probably you need less. So I really think that even 20 patients that are going from Asia compared to Caucasian be really interesting to at least open the door for discussion, because I cannot agree more that you probably are right. And I even agree more when you say that carvedilol has some potential beneficial effect because low dosage are not compatible with bisoprolol. So we need more Asia population data, especially in this setting. But we have to consider, I just want to tell that I want to open the mind with the different thinking. So I'm not saying that is your experience is always good, okay? But we need to demonstrate something. I prefer use carvedilol always because give me more time to have no negative effects.
Even we know that carvedilol is not beta-1 selective, not fully beta-1 selective compared to bisoprolol.
You know, that's very good point. In acute heart failure, the alpha activity is greater than the beta activity. So the advantage of alpha blocker activity is a kind of vasodilator activity that is more important than the beta blockers. So you can have both things going together. But alpha blockers in acute phase is the most relevant one.
Okay.
Because in acute heart failure, vasoconstrictions is the most important physiopathological mechanism.
Yeah. Okay. Due to limited of time, you have already in 10 o'clock in the morning the cardiology. Okay, because
I have a special question. Actually, I have many patients, not many, few patients, especially after the heart attack and optimal medicine with a ACE inhibitor, beta blocker, and also a chronic heart failure patient already stable. The most important question they ask about me is a problem, erectile dysfunction. Erectile. So I have some patient I changed with Nebivolol. What your recommendation for this issue? Actually, I cannot blame which the medicine can cause the problem. Maybe 10 patients ask about that. Maybe another patient not wanna ask about that. But I think it's quite a big issue for me to give the best medicine for the heart failure.
Okay, that's not important. Erectile dysfunction is improperly linked with the beta blocker use. Erectile dysfunction is a symptoms of cardiovascular disease. So the link between negative effect on penis function at the blockers has no evidence. No evidence at all. It's anecdotal. Erectile dysfunction is coming for diabetes, coronary artery disease, hypertension, heart failure per se. So let me tell you, if you have a patient on beta blockers, even not heart failure, with hypertension, okay, that has erectile dysfunction, is not because of beta blocker, it's because he has kind of atherosclerotic disease in his organ that is reflecting already coronary vessel disease. I was involved in this research with the new drugs such as sildenafil, and I was really showing that there is no really relationship between beta block. So I remember first trial I did in 1974, patients with hypertension coming, complaining with erectile dysfunction of beta blockers, okay? And I say, okay, stop beta blocker, okay? And it came up, I said, oh, now I'm okay. I got really a son, so I'm doing very well. Oh, congratulations. And I say, okay, now could you take again beta blockers? And he took again, and the erectile dysfunction was not coming back. So I assume that this link between erectile dysfunction sometimes, yeah, I don't exclude that can occur, but occur with calcium inhibitor, calcium antagonist, with sometimes ACE inhibitor, and this because it's not linked to the drug, but the cardiovascular disease per se. Erectile dysfunction is a vascular dysfunction. So it's a kind of atherosclerotic process. So I cannot say that all the antihypertensive and cardiovascular drugs can give some negative effect on that, but it's not really because of, so I suggest you stop beta blockers and see if the erectile dysfunction is still there. Think about the possibility that is a kind of predictions of a future myocardial infarction. So you say, okay, stop, but you have to check again your patients if the issue, if the issue, like I assume, is not solved. This was not related to the drugs, but to the fact there was ongoing atherosclerotic vascular disease. So it is another question that is important. And the same for diabetes. Diabetes is not affected by cardioselective beta blockers. COPD is not affected by beta blockers. So there are a lot of, I don't want to think that there are not specific patients that you can have, but this can occur with antihypertensive drug, okay? Not a beta blocker per se. But I cannot exclude that all these cases are going to be probably true. I don't want to say, but I just want to encourage you to think about that should be not really, so because we are too much probably thinking some kind of, because sympathetic activity is linked with our sexual function. That's not true. I mean, the sexual function depends on the vasculature of the flow. I don't know if it is, but it's a kind of experience that I just ask you, please check again if the patient has solved the problem. It's just, I just want to raise your mind to think a little bit differently. I don't want to say that you are wrong because I have not the power to say wrong, but just open the mind differently. Should this is a sign of coming myocardial infarction? You know what I mean? Or is the drug related? Or probably both, something like that.
Yeah.
Yeah.
Your statement about the COPD. How about your experience about the patient with the COPD, acute exacerbation, about this beta blocker? Do you stop that, or the patient with the asthmatic with the routinely taking beta blocker?
No. With asthma, I stop beta blocker. With asthma, there is the clear reason to stop beta blocker, even cardioselective one. So there is no doubt that if the patient's asthmatic COPD, there is no room for beta blockers. Definitely, I prefer a calcium antagonist because they have some positive effect on, if I have to treat patients with the COPD with asthmatic consequence, I prefer calcium antagonists because they have some positive effect on bronchial musculature. If the patient has COPD with asthmatic disease, I stop beta blocker. With the COPD alone, without asthmatic effect, I think I can, cardioselective, I can use. So COPD per se without asthmatic phenotypes, I think beta blockers is no contraindication. But if it's asthmatic phenotype, you should stop beta blockers.
So should we say that if there is an exacerbation of the COPD, we have there is a sign of, maybe there is a reasonable sign that we stop temporarily for beta blockers if the exacerbation of COPD?
So patients come in acute phase, with the COPD and beta blockers. Okay, I did a trial and a paper I published 45 years ago in patients with tuberculosis, very severe COPD. I was measuring FIHA, and I was giving these patients with acute tuberculosis and the COPD beta blockers infusion. There was no negative effect if it's cardioselective. So if it is cardioselective, there is no reason so that you have to stop again. You can modulate a little bit, but again, selective beta blockers is not carvedilol, is atenolol or metoprolol. In the COPD are not contraindicated. Definitely. If it's asthmatic, is another story.
Dr. Susilo, anything that you want to ask a question?
No, you want to come back on this?
I studied with another hospital in Harapan Kita Hospital. My mentor said, if you find the patient with the left heart failure complicated with the right heart failure, and the systolic, the right ventricular function become low, it means we with the TAPSA, the echocardiography, and we calculate the TAPSA is less than 1.6. My mentor told me to stop the beta blocker because it's the negative effect for the right heart failure, for the left heart failure complicated with the right heart failure to taking the beta blocker. Do you have any experience or opinion for that? Thank you.
Okay, that's another fantastic question. Are we talking about pulmonary hypertension or as a consequence of COPD? Or you talk about the left ventricular dysfunction complicated by right? So increase the pulmonary wedge pressure, right? So the question is if a beta blocker is increasing pulmonary resistance, right? Because the reason to stop it, because you think that, let's say, right ventricular pulmonary artery vessels are more constricted, right? So in beta blocker negatively affect the pulmonary resistance. Is that the reason? So, and the wedge pressure, it depends. Let me tell you that it depends how much are you going to balance the beneficial effect of left ventricle, right? With the, because if the right ventricular increased pressure is due to the very poor left ventricular function, okay? So if this right ventricular increased pressure is because the left ventricular function is very depressed, so you have a wedge pressure increased, and then resistance of the pulmonary vessels is increased, right? You should work on the left ventricle, first of all. And can you follow me? So you have to always work on the reason of increase the right ventricular pressure. If the reason is left ventricular very poor, work on that, diuretics, a little bit beta blockers, and then you are going to check if there is still remaining need to work on the right ventricle. So my final vision is that always check which is the reason of this right ventricular increase. Okay? If, of course, if a patient has a primary pulmonary hypertension, is not the beta blockers, the right drug, but it's a different story. You have increase in pulmonary artery pressure per se. If you have left ventricular pressure very depressed, and then wedge pressure is increased, work on left ventricular pressure. Give diuretic, give ACE inhibitor, give small dose of beta blocker. Once the left ventricular function is ameliorating, check the echocardiogram, tricuspidal valve function, and see if there is really need to reduce beta blocker. So I just want to say again that you have to work not to consider, oh, I have right ventricular increase in pressure, I need to stop beta blocker. Okay? I think that is a case where I have to work on left ventricular function to make sure that left ventricular function is ameliorating and see if I can reduce vasculature vasoconstrictions. And then if and I understand that, you know, okay, everything started with the fact that I was one of the first person in the world that I was thinking that beta blockers were good for heart failure, right? So that was at that time a kind of revolution, because probably you are too young, but I remember that I when I came in the cardiology clinic, oh, they will say, don't use beta blockers for heart failure, right? So that was, if I was not insisting at that time, I was contributing to the use of beta blockers in heart failure. I was so happy because at that time I was coming from a London experience, my mentor, that was beta blockers in left ventricular hypertrophy from hypertrophic cardiomyopathy, right? So there are a lot of basic concepts that brings me to think about differently. So remember that beta blockers were contraindicated in hypertension because beta blockers vasoconstriction. A famous paper from Tarasi showed that at the beginning you have vasoconstriction, but the vasodilation is acting very after. So I think that also in this case, that is, if you have pulmonary hypertension, primary pulmonary, of course, is a structural resistance increase. Beta blockers, you have no reason to give. But if you have a consequence of left ventricular dysfunction, take care of that and see if you are have some beneficial effect. Then you can consider to stop beta blockers. So I just want to let everybody think a little bit differently on physiopathological mechanism and don't consider beta blockers a vasoconstrictor. That is coming all the question, right? I don't want to make you too much change your mind, that I think you should consider your concerns, because I don't want to change mind, but try to open the mind. I hope that this discussion was fruitful to think sometimes a little bit differently. I don't want to say that you have not the right to think, but just, you know, that's the story why many people are skeptic about natriuretic peptides, right? There are evidence that you have to think differently and to think how can we try to put our mind in single case to look at the evidence. So it's a kind of a job that is sometimes a funny story, right? I like this job because it makes my mind active.
Okay, thank you very much for your.
Thank you to you. It's been very fruitful for me too.
Give applause. Thank you, Professor.
Can we make a photo, right?
Yes, before we end this discussion or scientific meeting, should we take a picture?
Foto-foto. Mana kita aja. Foto-foto itu kan bagiannya.
We are so thankful for the lecture that was given to us, and now we are going to take pictures together. So all our supervisors and invited guests, please come forward. Please come forward. We're going to take picture together with Prof. Salvatore.
Tidak bisa alisan lagi. Enggak, soalnya ini. Kalau nggak saya juga nggak pakai apa. Mandi aja alhamdulillah jadiannya.